Thanks for coming for tonight. We're going to talk about menopause and fibroids. I'm Samantha. I'll have to introduce Tara Shirazian, Dr. Shirazian, and also Dr. Kelsey Castle. This is our Center for Fibroid Studies. We also have Dr. French here. She'll stand up in the front. And then also Dr. Kristen Fine, also with the Center for Menopause. And I'm part of the Center for Menopause. And we have our two fabulous MPs, and thank you for starting. So tonight I'm going to talk about just some definitions and demographics. I'm going to talk about menopause in general. We're going to go into some treatments, so fibroid specific things, and then indications, contraindications for different therapies. But so this is a pretty, I think, the best graphic I've seen to understand what menopause is. So we know menopause average age in America is around age 51, 52. There's a big range of when it can happen. About 90% of women undergo menopause between ages 45 and 55. So the other 10% before or afterwards. But the time that's really interesting is this menopause. It's also called the climacteric, and it's also called the menopause transition. So that those words all describe that same time. And it's when things are changing, when ovarian function is slowing down, leading up to that year where there's no ovulation, and that leads to what we see as not having periods anymore. So it's that 1 year. It's always recognized retroactively when people say, "Oh, no, I don't have my period anymore" for a year, and that's the day of menopause. So everything before that is premenopausal, and everything after that is postmenopausal. There's an interesting thing about perimenopause is that it does kind of go into the after menopause, because there's still 2 years where people are kind of acclimating, and yet there still might be like a big ovulation, and it's considered early postmenopause. So that's just definition. So this is a scary slide, but this describes the physiology of the transition. So we break it into the early menopause transition and then the late menopause transition. But early and late is really perimenopause. So early perimenopause is recognized by women when they start having shifts in their cycle. So the regular cycles come in every 28 days. We'll say the ideal cycle, although it doesn't really happen like that, but most of the time it's predictable, somewhat regular. You can anticipate when it's going to come. At the early perimenopause, it starts to shift. It either becomes 7 days later or 7 days earlier. The cycle will be a little bit shorter, maybe even some heavier bleeding. So the bleeding shifts in some way, and that's early perimenopause. The other thing that happens in early perimenopause is this thing called the luteal cycle, and it stands for luteal out of phase event, and it causes chaos in the hormones. It happens about 1 out of every 4 cycles. I'll talk more about that, but it leads to some of that hormonal chaos. So people can have symptoms at this point. They can have vasomotor symptoms. They can have joint aches, they can have mood change, sleep disruption. It's not as common as later in the late perimenopause or even the postmenopause. So moving into the late perimenopause, this is when periods skip. So there'll be a 2-month period, 60 days where there's no bleeding. They'll skip up for 3 months, 6 months, and this is the late perimenopause. The timing here for the total time could be anywhere from 4 years to 7 years to 10 years. So I know it can last for a long time. It's not like a blink. It doesn't happen a year. It happens over a long time. And you can imagine this is really what's going on is the ovaries that used to be kind of taking signals from the brain and having this regular action is now they're just not behaving like they used to. So the cycles are spread out, the hormones are a little more chaotic, and over time they just decide to not work. We don't know why menopause happens. There's some genetic component, there's some environmental component. Symptoms are different for different groups of people, but we don't really know why menopause happens. Same way we don't know why, primary birth happens, like we just don't know. So this is a cycle. This is a picture of the menstrual cycle. So all the medical practitioners are familiar with this. Everyone gets a little shiver down their spine because we are always tested on this. But the important thing that I want you to notice is just this really beautiful complex interplay between estrogen going up and coming down, and then also FSH going up and coming down. And here's this progesterone, which is that other hormone that we think about with menopause hormone therapy going up and coming down. So this is the regular, predictable cycle that happens month after month. In the mid-cycle, there's ovulation, and that's if someone has PMS, this is when they're going to start feeling PMS, and that PMS is going to continue as this progesterone is going higher in that second half of the cycle. It's called the luteal phase cycle, luteal phase part of the cycle. So this is a slide that's from a group called Women Living Better. They're a great organization online, not for profit, and they allowed me to use this graphic representation of, again, over a 6-month span of time of a premenopausal woman, a woman who's in the perimenopause, and a postmenopausal woman. And you can see the regularity here with estrogen and progesterone, really even peaks and valleys. And then you can see the chaos of hormones here. This is from a single woman over 6 months. This is from work that was done in 1996. And then this is postmenopausal. We see the very low estrogen, the low progesterone, with the elevated FSH. So this is basically that transition over time. So this is the loop event, and the loop events I think are important when we think about fibroids because it leads to these scenarios. And there's some theory, we don't know for sure, but that we know fibroids grow in the perimenopause. And there's some theory that it's these elevated levels of estrogen that can lead to them growing. They may also be growing because of age over time, but it's something to think about and consider. So this is when, because of these elevated FSH levels, first we have one follicle that's recruited, and so the estrogen goes up like it's supposed to, but then because the FSH is so high, it recruits another follicle, and this creates this really, really high level of estrogen. So these peaks of estrogen can lead to the PMS symptoms like the breast tenderness, sometimes migraines. It can lead to heavy bleeding and irregular bleeding. It may lead to fibroid growth and can lead to something called endometrial hyperplasia as well, which can be like a precancerous condition. So next slide, please. So in terms of the abnormal uterine bleeding, it's just really important to track your bleeding patterns during this time. We don't blink when people have lighter periods that are coming further apart. We are really interested when people are having heavier periods that are coming closer together and are longer. So, and that's because we think about the risk potentially of hyperplasia or precancer. Most of the time, heavy bleeding is not due to those things, but we want to hear from our patients if they're having that experience, even during the perimenopause. One of the hallmarks of perimenopause really is abnormal bleeding. So, we don't want to make it a pathology, but it's something just you should be aware of and touch with your practitioner if you have a problem. So basically, this is what heavy bleeding looks like. Like if you're talking to your doctor and they're not responding, you're saying, I'm having bleeding. This is what you can tell them. I'm having bleeding for longer than 7 days. I'm passing clots. I'm soaking through products. I'm gushing when I stand up. I need to double up on menstrual products. So when that happens, you've exceeded the norm. There's a problem. So that's a clue for you and for your healthcare practitioner. So in the perimenopause, we often use the pill, which is, or the ring, or the patch, which is basically a combination. And what this serves to do is suppress those ups and downs and kind of like washes the endocrine environment so that everything is, it's not like menopause, but it's just quiet and smooth in terms of ovarian suppression. So you have constant level of estrogen, constant level of progestogens, and you're no longer ovulating, so you don't have this chaos. It's the chaos that affects the mood, that affects the sleep. So, we can bypass this, and if you're having abnormal bleeding, it can be an option once you make sure that nothing else is causing abnormal bleeding to kind of get you through the symptoms of perimenopause and mask the symptoms of menopause until you're in your early 50s, assuming there's no medical. Then in terms of like, what do we think about for menopause? So bleeding is a big deal, but not everyone has bleeding. There's also a number of other symptoms. The symptoms range from the physical symptoms that everyone thinks about, like the iconic hot flashes, night sweats, vasomotor symptoms. Mood symptoms are really common, especially depression, and then anxiety, irritability. I had a woman tell me today that she became the Hulk. Like on occasion, she has some rage episodes, which is common, not uncommon, I would say. There's heart palpitations, and then there's general urinary syndrome menopause, which is basically vaginal dryness. So pain with sex and also changes in libido is not uncommon. So, you know, everyone has their own experience with menopause. There's no like one thing that happens to everyone. Some people don't have symptoms, the lucky few, but most people have a little something as they're going through this. Regardless of symptoms in the background, other risks change at this time. So risk for bone loss happens now. Risk of cardiovascular risk accelerates now, and just the general urinary tract in general kind of can suffer at this time because of the decreased levels of. Next, please. So this just talks about how you know, when we think about the median duration of vasomotor symptoms, which is the most common, one of the most common symptoms, it really is cultural. So we know this from a study called the SWAN study, which looked at like 3,000 women over the US. And it gathered data from different groups, from white women versus other groups of women in different, like 7 different cities across the country. And it was really interesting because we didn't know this before, but the median is like 7.5 years, but Black women have symptoms that can last up to 10 years. So that means severity and frequency is greater and duration is longer. And then Hispanic women are a little bit less at 8.4, and then Chinese women a little like 5+, and Japanese women just under 5 years. So these are just the groups that they looked at, but it really gives us a sense that symptoms are not like one size fits all. It really depends on the person's you know, background and cultural experience. So these are what we do for symptoms. So you know, hormones are estrogen and progesterone, and they're the gold standard for treating vasomotor symptoms. There's lots of different combinations that we use. If somebody doesn't have a uterus, thank you, surgeons. Estrogen therapy is a great choice. And really it's estrogen that takes care of these symptoms. If somebody does have a uterus, they have to use estrogen and a progesterone. Off-label, we often use just a progesterone only. Sometimes that works to suppress ovulation for people who can't take an estrogen medication. There's also something called a TSEC, which is Duobi, and that offers estrogen with something that's like gestogen, but not exactly. And then there's some other medications too that are right now. So, you know, why do we use hormones? So there's the direct like FDA indications, vasomotor symptoms, for people who have osteopenia to reduce risk fracture risk in the future, and for genital urinary syndrome. So these are the big 3, but we also use it for like other indirect benefits as well. So people who have sleep disorder, you know, sometimes we'll try for someone who has joint ache, someone with mood in the late perimenopause. Sometimes we'll trial hormones with them, assuming that there is no contraindication to them using hormones. So it depends on, you know, that's really a shared decision-making process. It's very individualized. So these are the main reasons. And then who doesn't get hormones? So these are people who have like unexplained vaginal bleeding. We want to be sure we know why someone's having bleeding. Somebody who's had an estrogen-sensitive cancer in the past, so either breast or endometrial or ovarian, especially for a later stage endometrial or ovarian. For triple-negative breast cancer, because it's sort of a different cancer than estrogen-positive cancers, we can use hormone therapy in people who are symptomatic after 5 years because they're considered cured at that point, unlike the more common estrogen-positive cancer where they're still in remission. People who've had coronary artery disease like stroke or heart attack are not good candidates for hormones. Also, if they have a very high risk of thromboembolic disease, so someone who's had a DVT or PE in the past, it can be risky for them to use estrogens. And lastly, someone with like severe active liver disease, so that's like cirrhosis, like really disease. And peanut allergy is just because of one medication, but they're all are alternatives to that, so it's not as strong. So, but I want to bring out the one thing that's not on that list of contraindications is fibroids. So fibroids are not a contraindication using therapy, and Dr. Shirasi and Dr. Kelsler are going to talk more about that. We're going to have time for questions afterwards.
Yeah, I think we'll take questions after, but we definitely want to hear from all of you and just kind of know any concerns and what you're thinking. Thank you so much, Dr. Dunham. I'm going to turn the mic over to Dr. Castle now, who will represent our Center for Fibroid Care team. She's going to speak about fibroids. Okay, you don't want to?
I just
Okay, so I'll talk a little bit just background-wise. What are fibroids? I'm not sure how familiar everyone is in the audience about fibroid disease, but it is what we focus on at the Center for Fibroid Care. And this whole talk came about because we had so many patients that were perimenopausal or menopausal and had questions regarding their fibroids. Questions like, well, okay, my fibroids are really large now, what should I do? I want to have them removed, or we want to go on hormone replacement. Is it okay, doctor? I have fibroids. You know, these were some very common questions the whole team would get asked. So we thought this would be a timely topic. So for those who don't know, uterine fibroids are non-cancerous growths of the uterus that affect the myometrium. It's the most common tumor worldwide, affecting 80% of all patients worldwide. It is across all races, although we do see racial disparity in fibroid disease, with Black women being the most commonly affected group. We deal with it a lot in women in childbearing years, and of course, the reason that it's so significant in women under the age and under the menopausal age is because it can affect fertility, it creates a lot of heavy bleeding, it's really can be very symptomatic for a lot of women, and they grow until menopause. And so that's the key here. At menopause, the growth starts to stabilize, but I think one of the very important points is you don't all of a sudden undergo the menopause transition and then the fibroids disappear, right? The fibroids stay and very slowly shrink over time. If they shrink, well, they shrink, but very, very slowly. So for some women, it's like a decade, it's 15 years later, and if they had really large fibroids, they're still feeling those fibroids. And those are patients that we all often see in the office. So these are some of the symptoms of fibroids. They're obviously that heavy menstrual bleeding, bulk symptoms. Bulk and pressure are what we typically see in the menopausal transition and beyond. So women still feel those really big fibroids and often come in way after menopause. I feel like women sometimes feel duped. Like, you know, they told me my fibroids were going to shrink in menopause. Why do I still have these big masses? And the reason is that the shrinkage is very slow over time. They stabilize and slowly shrink. Okay, next slide. So we talk a lot about hormone replacement. And so estrogen can cause the growth of fibroids. And so when we have high levels of estrogen premenopausally, the fibroids will grow. The higher the estrogen dose, the more likely fibroids will grow. But an important piece is hormone replacement. When you start that, we think overall it probably does not increase the rate of growth. I actually did a comprehensive lit search on this topic in preparation for tonight, and there's no great data that hormone replacement increases fibroid growth. So we think that likely it just kind of keeps it stable. You know, maybe it doesn't shrink it, but it will kind of keep it stable. It should not increase the growth overall when you look at all the studies. although of course more research is needed, you know, in the scenarios in which you're using very high levels, those obviously more research is needed there. But in general, we think it's safe to take hormone replacement even if you have fibroids. So that's sort of the take home. Yeah, I'm gonna turn it over to Dr. Castle now for management.
Yeah, so we kind of wanted to go through like common scenarios that we would see as providers here as part of the Center for Fibroid Care. Common patient experiences that would bring you guys to us for an intervention and kind of go through some interventions that we have for patients. I think, you know, from Dr. Dunham's kind of talk, we talked a lot about how there in perimenopause, there can be kind of these erratic hormone levels that even in a woman without fibroids could lead to a lot of disruptive bleeding. I think fibroids just are another layer. You know, I say to patients, like, maybe you have a fibroid where you could have been like more or less asymptomatic, but then you added kind of that erratic hormone signaling as like the icing on the cake. And we took somebody who was kind of getting along okay with their fibroids, and all of a sudden, you know, that's really what peaked their symptoms in terms of heavy bleeding, for example. So kind of, we'll go through some interventions, but like management of heavy bleeding, management of just heavy or abnormal bleeding, maybe that didn't start until we initiated some hormone therapy, and we really want to optimize so that patients can stay on hormone therapy, so that they're getting their hot flashes treated, and then bulk symptoms as well. This is a nice slide that just kind of goes through everything that we'll talk about, kind of from least invasive to more invasive. So everything from medications kind of on the least invasive side to some smaller vaginal procedures. Uterine artery embolization is something done by our interventional radiology partners, and then kind of like laparoscopic or bigger surgeries. So one big thing that we all wanted to make sure that was a big take home point for tonight is that, you know, we want to make sure that we are doing kind of an appropriate workup, keeping patients safe. We touched on not many of us bat an eye when somebody's perimenopausal transition is for periods to get lighter and lighter and space further and further apart. Nobody worries about that. But what doctors start to worry about is when we hear about heavy bleeding, prolonged bleeding, bleeding in between periods. These are all common symptoms of perimenopausal transition. They're also common symptoms of fibroids, but they are a potential symptom of precancers of the uterine lining, which is also known as hyperplasia. Endometrial cancer is one of our common cancers as women. So we don't want to miss that. You know, we don't want to go ahead and claim perimenopause or claim fibroids. We want to do appropriate biopsies and samples. So if you're a patient who is having kind of any of those bleeding profiles that I just went through, then we want to do appropriate endometrial sampling. That can be done in the office, like in the bottom corner here is a picture of a small little, we call it a pipette, it's like a straw that we can pass through the cervix in the office to do an endometrial biopsy. We always want to make sure we're doing that in a way that's comfortable for patients. Sometimes it can be done comfortably in the office, sometimes it cannot. So if that is something that can be done comfortably in the office, then we sometimes will do it under anesthesia, and then we're usually looking at more of what we call like a DNC procedure. Usually if I'm doing a DNC procedure, I always do what's called hysteroscopy, which is just looking inside the uterine cavity with a camera, so that I can make sure there's nothing in there that's an obvious cause for someone's abnormal bleeding. So those are kind of sampling procedures we offer patients. So beyond that safety check, I'm going to go through more interventions that should be helpful for symptoms. So medical management. So if someone is having heavy bleeding, prolonged bleeding, irregular bleeding, then we can sometimes manage it medically, depending on kind of what they have going on with regards to their fibroids. We use birth control pills. Dr. Dunham might be able to go through this if anybody has questions about it, but some patients actually do well with a low-dose birth control pill, also to manage some of their perimenopausal hormonal symptoms, kind of keeping like more of a steady hormone signal instead of what might be more erratic, what's going on with them. But that can also like bleeding. We use progesterones. Progesterones basically just help thin and stabilize our uterine lining so they can make bleeding lighter, potentially that bleeding to just stop altogether. Progesterone IUDs is a really nice localized option for patients. I always talk about progesterone IUDs if I'm doing any procedure under anesthesia. It's kind of an ideal time to get it in because it is another uncomfortable office procedure. So if we can place it under anesthesia, we can make that kind of concern for patients a little bit easier. There is a newer class of medications, or GnRH analogs, some oral medications. Those medications are a little bit stronger in terms of reducing heavy bleeding. So we do use them a lot if we haven't gotten good control of heavy bleeding with some of our more basic hormonal medications. They can sometimes, for some women, shrink the fibroids a little bit. So aside from targeting heavy bleeding, they might also help with that. But that it's not in every woman, so I don't rely on them for that kind of indication. So hysteroscopic myomectomy. So there's a nice picture down here in the bottom corner of the page of what a fibroid uterus could look like. Fibroids could be anywhere kind of within the uterus. We have a procedure called hysteroscopy, again, looking inside that uterine cavity with a camera through the vagina that would allow us to remove these submucosal fibroids that are pointed out here in this picture. These fibroids, if they're small, even if they're small, they can still be the source of pretty dramatic heavy bleeding for patients. So for sure, somebody who's struggling with heavy bleeding, someone who maybe starts to have some irregular bleeding, starts hormone therapy and has those sort of issues pop up. If we do an ultrasound and we see a submucosal fibroid, then that's kind of something easy that we can take care of and kind of remove with a small hysteroscopic procedure, all done through the vagina. It is only going to target those ones that are kind of pointing towards the inside of the uterine cavity, so it's not going to get at other fibroids more in the muscular wall. So it's limited in what it can accomplish, but those can be the most troublesome fibroids sometimes. And that's a nice little picture of what we might see on hysteroscopy, just kind of a big fibroid just filling up the uterine cavity. Another intervention that we can do transvaginally is an endometrial ablation. A specific endometrial ablation procedure that we're kind of showing a picture of here is called the Serena procedure. In general, what endometrial ablation tries to do is basically burn the uterine lining such that in a perfect world it would never grow back at all and someone would have no periods. In reality, most often what's happening is we're just going to reduce the heaviness of periods. This Serene endometrial ablation is really nice because it uses something called cryotherapy, which is kind of like a freezing instead of maybe it's more of a burning. The benefit of that is it's actually very minimal pain. So this is actually something we can do in the office, which is wonderful. Some procedures like the Serene and a few other endometrial ablations that we do, they don't really cause a lot of scarring within the uterine cavity. So if we did need to go to any other procedures inside that uterine cavity, like biopsies later, if someone continues to have bleeding, then that's kind of a nice benefit. And sticking with vaginal kind of interventions, we have a great intervention called a Sonata procedure, which is a probe again through the vagina and into the uterus that allows us to target fibroids that are more in the muscular wall. So remember with that hysteroscopy, I could only target those submucosal fibroids, but with this we can ablate fibroids in the muscular wall and we can shrink and soften them. So it helps tremendously in terms of reducing heavy bleeding related to fibroids. And I started to kind of transition into now we're really shrinking fibroids. So this might actually be something that's going to benefit someone who also has some of those bulk symptoms like pressure, heaviness. Urinary frequency is something I see a lot with fibroids in general, and especially sometimes as I think our estrogen levels are declining. In perimenopause and menopause, some urinary symptoms can become more prominent. So patients are kind of having those bulk symptoms, and with this procedure, by shrinking fibroids, hopefully we're not just going to help with heavy bleeding, but also those bulk symptoms as well. I think we have a video here.
Yeah.
It should be pretty short. Does it have a?
No.
No. So this is just a great little video that just shows it. Again, it's a probe that goes through the vagina into the uterus. It allows us to kind of see the fibroids in the muscular wall, and then a small needle just gets stuck right into the fibroid and treats it with that radio frequency ablation. So I almost equate it to like a microwave type of energy. So it's kind of zapping the fibroid, getting it to shrink and soften. We can, target as many fibroids as we can find with this procedure. There are some fibroids that might be too big or in a location too far away from the uterine cavity to treat. This is really nice because I think, historically we've had that hysteroscopic approach to those kind of submucosal fibroids, and then if someone wanted to do, something to treat the other fibroids in their uterus, kind of the next step that we had to offer them was bigger surgeries and laparoscopic surgeries or things. And so with this, we can at least start to treat these kind of intramural fibroids and get them to shrink and soften, and that's really nice. The uterine artery embolization is another procedure that shrinks and softens fibroids. It is done by our interventional radiology colleagues. They basically can use an artery in your wrist and travel to the uterine arteries to close them to decrease the blood supply to fibroids and get them to shrink. So again, helpful for heavy bleeding, also helpful hopefully for bulk symptoms. I think, compared to the last procedure we went through, this is going to kind of target the whole uterus, all the fibroids in the uterus. So there might be someone who might be a slightly better candidate for this procedure if they have a tremendous number of fibroids or really, big fibroids that wouldn't be able to be treated with that Sonata device. And then kind of at the far end of the spectrum, we have kind of our, more of our kind of abdominal surgical approaches. We always try to offer minimally invasive surgery when we can. Small incisions will reduce pain during recovery, lower complication rates, and get you home same day from the hospital. Probably one of the more main surgeries that we talk about doing for fibroids when we're more in the perimenopause and menopausal range is hysterectomy. So removal of the uterus. It is definitely going to be the most definitive procedure. With no uterus, you have no bleeding anymore, and no chance of fibroids coming back. Compared to just shrinking fibroids, there's not a question of if it's small enough for you to feel good. It is just not there anymore. So it is definitely going to be the most definitive approach for patients, which some people like. I've had some patients come into my office having tried 10 different things and really needed to do that to come to hysterectomy at the end. I've had other patients who come to me and say, sign me up for hysterectomy tomorrow because I just need to know that I'm not going to be back in your office in a year dealing with the same problems that I'm dealing with right now. So we don't have a big toolbox for patients, and sometimes one tool is a better fit for some people. That's kind of the pro of this one, is it's definitely the most definitive. Dr. Dunn had mentioned that with no uterus, your hormone therapy and menopause will be simplified. It'll just, for the most part, be estrogen replacement therapy, not needing a progesterone. You can correct me if I'm wrong, but I think one of the main reasons women discontinue menopausal hormonal therapy earlier than they would have wanted is bothersome bleeding. And so, I think hysterectomy definitely can optimize that situation again in terms of just not having any bleeding.
So I think maybe we'll leave so the last two slides are just on non-hormonal therapies, more lifestyle and supplements, but I think we could get to that in terms of questions. The one takeaway, thank you so much. For that, is when you're in perimenopause and you have fibroids, we can do a lot of things to help bridge into menopause. So some of the more minor interventions we use as a bridge to help you just bleed less, have less symptoms, and kind of get through that menopause transition. So I think that's one really unique thing about that. All right, any questions? Yeah, I'm going to do the mic. I don't